I would request to our chairperson to call Dr. Swapnil for that.
I welcome to Dr. Swapnil Pathak. Topic is diagnostic evaluation of dyspnea in clinical practice. Dr. Swapnil Pathak done his MBBS DNB in Max Hospital, Delhi. Now he is a pulmonologist in Breath Easy Multi Hospital, Ramnagar, Varanasi. Welcome to Swapnil Pathak.
So at the outset, I would like to thank all my seniors, teachers, all the delegates, and all the stalwarts of pulmonology sitting over here. So my lecture is basically stick to the basics, back to square one. So we are talking about dyspnea today. Dyspnea per se, which is a multifactorial cardinal symptom that basically inculcates respiratory, cardiac, and other causes of dyspnea. So let's dive into this lecture. So firstly, we'll discuss the definition of dyspnea per se. So as per the ATS consensus definition, dyspnea is a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. The experience derives from interactions among multiple physiological, psychological, social, and environmental factors and may induce secondary physiological and behavioral responses. So the point of discussion is, so dyspnea is a subjective kind of experience. Different individuals can experience this symptom in different ways. So the prevalence is 25% of the emergency visits are due to dyspnea, varying with the intensity of dyspnea per se, the amount of hypoxia the patient has. Leading cause of disability in COPD and chronic heart failure. And distinct forms are basically the patient is tachypneic and they might hyperventilate as well. We'll discuss the key differences. So dyspnea is a subjective perception. Tachypnea is the increased rate of breathing. And if there's a depth also increased without the rate increase, that might be a hyperapnea. Orthopnea is a postural variation. Platypnea is also a postural variation, and trypopnea as well. So these are basically different terminologies that are we using with respect to dyspnea, whether the postural association is there or not. Acute dyspnea, the most important causes within 48 hours is a pulmonary embolism, pneumothorax, ACS, pulmonary edema. Chronic, which usually there for months to years, is because of chronic lung diseases like COPD, interstitial lung disease, even in chronic heart failure and patients of pulmonary hypertension, they experience this symptom. So pathophysiology is basically there are afferent signals that are being taken from the chemoreceptors at the respiratory centers, from the mechanoreceptors like J receptors, stress receptors from the chest wall, and they basically centrally processed at the brainstem, at the DRG, BRG centers and cortical areas. They ultimately generate an afferent copy compared with actual ventilation and sense of neuromechanical mismatch perceived as air hunger. And the efferent mismatch, basically neuromechanical dissociation, increased motor output versus inadequate mechanical response. So basically it is kind of perceived as work or effort of breathing. So three distinct sensory qualities. Air hunger is basically urge to breathe, chemoreceptor driven basically because of the chemical chemoreceptors by an increased PCO2 or decrease in PO2, and most distressing quality persists even with the normal mechanics. Work or effort. So we see in patients of COPD there is increased work of breathing. Patient is maybe symptomatically well. He is not having the sense of dyspnea, but the patient, if you see while examining the patient, you might see there is increased work of breathing. The accessory muscles of respiration are working, and the patient looks to be a little tachypneic, but the patient himself or herself says that I am feeling okay. So this increased work of breathing is the entity which is very commonly seen with COPD patients. And chest tightness, which is a hallmark of asthma patients, they usually present to us with a symptom of chest tightness. डॉक्टर साहब थोड़ा छाती में tightness सी लग रही है, सांस अच्छे से अंदर नहीं आ रही, which is a cardinal symptom of asthma patients. So it's a distinct quality of dyspnea. Etiology is majorly cardiac etiology, 30 to 40% cases. Pulmonary again hover around to 30 to 40% cases. Cardiac basically because of heart failure of acute coronary syndrome, valvular heart diseases, pericardial effusion or tamponade, cardiomyopathies and arrhythmias. And among pulmonary causes, COPD, asthma, pulmonary embolism, pneumonia, LRTI, pneumothorax, ILD, pulmonary hypertension. And then rest of the other causes, which are most commonly being anemia, metabolic acidosis, neuromuscular disorders like motor neuron disease, GBS, myasthenia gravis, deconditioning or obesity, which is a very common phenomena in morbidly obese patients. Their skeletal muscles are basically being deconditioned because of the obesity, and they might feel the symptom of dyspnea. And psychogenic and anxiety, these causes are there. And apart from them, apart from these causes, there are mediastinal pathologies like mediastinal lymphadenopathy, which can also cause dyspnea. So I've just listed the detailed systematic causes of dyspnea per se. I'll not read out these causes, but there are pulmonary cardiac causes, hematological causes, metabolic and endocrine causes, neuromuscular causes, psychological causes, and other causes. So we basically classify dyspnea into acute, subacute, and chronic dyspnea. Acute dyspnea is basically within minutes to hours. Acute asthma, acute COPD exacerbation, pulmonary embolism, pneumothorax, acute heart failure or pulmonary edema, pneumonia, cardiac tamponade, acute upper airway obstruction, anaphylaxis, and metabolic acidosis. They are basically presenting to us within minutes to hours. And subacute dyspnea, which basically persists for days to weeks, is because of pleural effusion. This is basically an insidious onset, so the dyspnea is usually insidious. Interstitial lung diseases, exacerbations, tuberculosis, anemia, pericardial effusion, pulmonary hypertension, pneumonia, they are basically in subacute causes of dyspnea. And chronic dyspnea, most of the chronic lung diseases or chronic heart failure, these patients are having chronic dyspnea for basically more than months to years altogether. So when we are evaluating the cause of dyspnea, first determine whether it is acute or chronic dyspnea. Then we see whether the patient is hypoxemic or not, based on the saturation or the ABG if it is available, and whether the cause is pulmonary, cardiac, or mixed cause. Is it life-threatening? That basically requires immediate exclusion of the important causes. When we see in ER, we might first of all rule out these causes based on the history and examination of the patient. So pulmonary embolism, tension pneumothorax, acute pulmonary edema, cardiac tamponade, acute severe asthma, acute upper airway obstruction, and ACS. So these are the life-threatening causes of acute dyspnea that we need to rule out first in order to systematically evaluate the patient further. So basically this is a basic flow chart that is basically correlating SpO2 with the arterial saturation. So basically normal oxygenation is around 80 to 100 mmHg in PaO2, and which correlates with the saturation of more than 95%. But the cutoff of hypoxemia in ABG is 60 mmHg, which correlates to around 90 to 94% saturation. So anything below 90 is clinically significant hypoxia. When we assess the patient clinically, once we are managing the patient, so check whether the onset is acute or not, acute, subacute, or chronic, that we already have discussed about. The character of the dyspnea, whether because of air hunger or chest tightness or increased work of breathing, or the patient cannot take a deep breath. So based on this, we have separate causes that we have already discussed. Are there any aggravating or relieving factors, as in the dyspnea is aggravating on postural variation like orthopnea, bendopnea, tripopnea? Is there any diurnal variation, whether the patient is having nocturnal dyspnea like nocturnal proximal nocturnal dyspnea, which is mostly seen in heart failure patients? Associated symptoms, whether the dyspnea is associated with chest pain in cases of IHD or hemoptysis. Hemoptysis is seen in case of pulmonary embolism, cancer, TB. Whether is it associated with wheeze or not, like in patients of asthma, COPD. If is it associated with fever or cough, seen in cases of LRTI. Whether there is pedal edema or not associated with the heart failure. So along with that, is there a PND sign or not? Apart from this, if the dyspnea is associated with palpitation, then might be seen in case of arrhythmias. Is there any B symptoms associated with dyspnea, like in case of lymphomas, amyloidosis, and is there a significant weight loss that might correlate towards malignancy or interstitial lung disease or a chronic lung disease? These patients are usually cachexic and have a chronic dyspnea on exertion. Functional impact, so basically we we basically functionally quantify the dyspnea based on MRC or NYHA scales. What is the change from the baseline to the current patient present? Once the patient present to us, we kind of correlate with whether the patient was at a lower dyspnea scale versus the current scale. Now, impact of activity of living, whether patient's daily activities of living are affected or not, what is the exercise tolerance based on 6-minute walk test, and other objective quantification. Again, basics, there are several scales, most commonly MRC dyspnea scale and NYHA class. Basically, NYHA symptoms encompass dyspnea, easy fatigability, palpitations, anginal chest pain. And for your kind information, we don't use, other symptoms like so dyspnea, easy fatigability, palpitations, and general pain, these are the common symptoms which are NYHA class symptoms. Anything more than equal to 3 MRC is clinically significant dyspnea, predicts future mortality risk in COPD as per GOLD 2026. MRC CAT scores, CAT questionnaire is used to assess the severity of COPD. Based on that, we grade group the COPD patients. NYHA correlates with outcome, especially in heart failure. And NYHA class 4 basically is correlating with the hospitalization rate of 40 to 45% as per the AHA guidelines. Again, physical examination, general vital signs, they kind of, based on that, we kind of label the patient whether the severity is high or not. So if there is tachypnea, significant respiratory rate more than 20, saturation less than 94, you need urgent evaluation of these patients. Whether the patient is using accessory muscles for respiration, is the patient cyanosed, or based on that, we kind of quantify the patient's severity, and whether the patient is basically febrile or having hypertension or tachycardia. Based on that, we kind of categorize the patient that it might be sepsis that is causing significant dyspnea. CVS examination, a raised JVP, usually in heart failure patients, PE, tamponade, SVC obstruction, mid-diastolic compression, they can cause the JVP to elevate. And displays apex in like in case of cardiomegaly, because of cardiomegaly, S3 gallop seen in case of heart failure patients, loud P2 in pulmonary hypertension, murmurs associated like valvular diseases, pericardial rub in case of pericarditis, and other causes. In respiratory examination, usually telltale hyperinflated lung with a barrel chest, kyphoscoliosis, chest asymmetry. On percussion, there might be dullness if there is underlying effusion or consolidation, a hyperresonance on percussion in case of pneumothorax. On auscultation, fine crackles in case of pulmonary edema or ILD, coarse crackles in case of LRTI, wheeze, obstruction, basically is denoting a bronchospasm, absent breath sounds in case of pulmonary, in case of effusion or a pneumothorax, and a pleural rub in case of PE or pleuritis. Peripheral systemic signs are also there that we might evaluate the patient upon. Based on that, pitting edema, if there is pitting edema, they can be, the causes can be heart failure, hypoalbuminemia, a chronic venous insufficiency, clubbing in cases of ILD, malignancy, suppurative lung diseases, cyanotic heart diseases, lymphadenopathy, if there is a lymphadenopathy, that might point towards a lymphoma, sarcoidosis, malignancy, or amyloidosis. Macroglossia, periorbital purpura, carpal tunnel, basically there are systemic signs of amyloidosis. So a few causes of dyspnea with a normal chest X-ray. Some airway disorders like asthma, upper airway obstruction, bronchiolitis, they might point toward a normal chest X-ray. Pulmonary vascular disorders like pulmonary embolism, primary pulmonary hypertension, intrapulmonary shunt, basically these are the causes, these are the pulmonary vascular disorders which might present with dyspnea but the X-ray is normal. Early parenchymal lung diseases like sarcoidosis, interstitial pneumonias, LRTIs, some viral or PCP causes, so they may have a normal chest X-ray. Cardiac diseases like angina, arrhythmia, valvular heart diseases, intracardiac shunt, neuromuscular weakness, metabolic acidosis, anemia, thyrotoxicosis, hyperventilation syndrome. So basically these causes are basically with a normal chest X-ray. So you might holistically evaluate the patient based on the history and examination. There are certain episodic causes of dyspnea. So dyspnea is basically absent intermittently between. So the causes may be asthma, acute pulmonary edema, angina, pulmonary embolism, hypersensitivity pneumonitis, vasculitic disorders, hyperventilation syndrome. They have an episodic dyspnea. So the point, the main topic of the lecture is diagnostic evaluation of dyspnea. So first, when we evaluate a patient with dyspnea, there are a few basic investigations or modalities that we do. So pulse oximetry, based on that, whether the patient is hypoxemic or not. So SpO2 less than 90%, clinically significant hypoxemia is basically there. And which is usually unreliable in case of carbon monoxide poisoning, methemoglobinemia. These are the falsely low SpO2 in these causes. A 12-lead ECG which we do to look out for whether the patient has RBBB pattern, S1Q3, T3 in case of pulmonary embolism, LVH, AF for some arrhythmias. So basically, these are the ECG causes where the ECG is usually abnormal. ABG to look for whether there is a perfusion mismatch based on the AA gradient and based on PO2, PCO2 and pH. We kind of see what could be the cause of dyspnea. CBC, a complete blood workup to look for hemoglobin levels, polycythemia for chronic, in case of chronic hypoxia, the patient has a higher hemoglobin, leukocytosis to rule out any infection, eosinophilia to look for Th2 inflammation, which is usually there in asthma patients, EGPA patients, and eosinophilic pneumonias. BNP or anti-proBNP levels in patients of chronic or acute heart failure, they have raised proBNP levels. A D-dimer plus minus a CTPA. If you are suspecting a patient of pulmonary embolism, then the D-dimer levels are usually high in them. And based on that, you might further evaluate with respect to CTPA. So for pulmonary causes of dyspnea, there are various modalities, pulmonary function tests and advanced pulmonary diagnostics. So this is a spirometry which we do for pre and post bronchodilator spirometry. So basically it sees various volumes and ratios. FEV1 by FVC ratio and FVC. Based on that, we quantify the disease, whether the disease is obstructive or restrictive or a mixed pattern of defect, and whether there is a bronchodilator responsiveness or not. Apart from spirometry, we see a DLCO level. So basically, it's a transfer factor for carbon monoxide to look for whether the respiratory membrane is patent enough or it is delivering the gas, exchanging the gases in a proper way. So usually DLCO levels are low in emphysema, ILD, and pulmonary hypertension, anemia. Normal or increased levels in asthma, obesity, polycythemia. It's very important to see the DLCO levels if we are suspecting some perfusion mismatch at that level. Lung volumes, we basically holistically see the lung volumes on whole body plethysmography. Basically, we see RV, residual volume, RV by TLC ratios to basically quantify if so once a normal routine spirometry does not rule in restrictive lung diseases. So when we see spirometry and we suspect there is a mixed kind of a defect, so then we proceed forward with the whole body plethysmography where we see different volumes like FRC, RV, RV by TLC, so that whether the restriction is there or not, and whether the obstructive pattern, if there is an obstructive pattern, then we might see whether the patient is having hyperinflation or air trapping. Based on that, we kind of modify our treatment. Bronchodilator responsiveness in patients of asthma or small airway diseases, they have a positive bronchodilator responsiveness. So this is a spirometry, a routine spirometry and a DLCO test, so just a pictorial representation. This is a whole body plethysmography in which we basically ask the patient to sit in a closed chamber, and then based on that we perform some maneuvers and get some volumes out of it. And the key point is the FRC pleth. We see the FRC pleth, and then based on that we calculate various volumes and then label the patient with respect to restriction and obstruction. This is an impulse oscillometry, which is a effort independent spirometry usually used in pediatric patients and in elderly patients where we are not able to do the FVC maneuver properly. For these patients we use iOS, and the most key point is, although it's not much in use commonly, but we kind of utilize this test for diagnosing small airway defects which are usually missed out on a routine spirometry. This is a FeNO test. FeNO is basically a fraction of exhaled nitric oxide. This basically indicates airway TS2 inflammation, which is there in patients of asthma or small airway disease. So it basically quantifies the active inflammation in the airways, so that we can kind of increase the dose of inhaled corticosteroids, or we might later on we might use biologics in these patients if there is a active inflammation is there. Still active inflammation, so we might use other accessory tests or maybe modify our treatment. This is in cases of undiagnosed unilateral pleural effusions, if we see that the pleural fluid analysis is not very correlating with the patient's history, and we are not able to make a diagnosis of the cause of this pleural effusion, a unilateral undiagnosed effusion. Sometimes the ADA levels are not very reliable. Sometimes if it is exudative lymphocytic with a mid-range or a lower ADA, and we are still suspecting it could be a pulmonary pleural origin of TB, or maybe malignancy, which is usually missed out on.
प्लीज सभी लोग साइलेंट रहे प्लीज.
So undiagnosed effusions are sometimes missed on the routine cytology, pleural fluid cytology, or the routine evaluation. So for these patients, we use medical thoracoscopic biopsy. Take biopsies from the parietal pleura, so that we can run the tests like cytology and other tests on these patients. So very promising results. Sometimes those patients who are missed on a normal diagnostic pleural fluid analysis, they are picked up on these via these interventions. So this is a navigation bronchoscopy technique which we used in our center. So basically for evaluation of solitary pulmonary nodule, sometimes we miss these patients and we are not able to evaluate these patients. So with the navigation bronchoscopic console, we basically navigate a virtual bronchoscopic pathway. Via that we enter using our different instruments like radial probe EBUS, and we kind of it's a little possible for us to reach the nodule and take biopsies from there. So this is a navigation bronchoscopy platform, and so this is a routine flexible bronchoscopy which we use in patients who are in those patients which we are not getting results on a sputum evaluation, or the patient not able to expectorate, not producing any sputum. For these patients, we use a flexible bronchoscopy with a BAL to get a diagnosis of LRTI or malignancy. From this flexible bronchoscopy, we can take endobronchial biopsies, transbronchial lung biopsies for evaluation of maybe malignancies or interstitial lung diseases. This is a curvilinear probe EBUS TBNA, or maybe with a TMC, for patients with mediastinal lymphadenopathy who are which we are not able to evaluate or not able to take samples from. We use these techniques to take mediastinal lymph node FNACs or cryobiopsies from these nodes. So this is a radial probe EBUS, so basically a normal EBUS, a linear probe EBUS basically, and this is a curvilinear probe EBUS from which we take FNAC samples from the mediastinal nodes. So apart from these pulmonary diagnostics, we also, the baseline investigation could be echo. If we see some abnormality in the ECG and you're suspecting a patient of maybe heart failure or ACS, we might get echo. And in patients of especially chronic lung diseases, they have a component of pulmonary hypertension as well. So look for the diastolic dysfunction, to look for the right heart pressures. We see these, we kind of utilize this echo transthoracic echo. Now, selected patients of suspected pulmonary embolism, we get a CTPA done. HRCT thorax should be a baseline investigation in patients of chronic or chronic lung diseases. A VQ scan not usually used nowadays. We basically go for CTPA in these patients. Selected cases, we go for 18 FDG whole body PET CT if we are suspecting some lymphomas or some malignancies. So a special test in patients of undiagnosed dyspnea. If you don't know the cause of dyspnea, we kind of utilize this test, cardiopulmonary exercise testing. So basically it basically measures all the ventilatory, respiratory, cardiac parameters in a single platform, and we out of this test we see certain values like peak VO2, what is the peak VO2 anaerobic threshold, V by VCO2 slope, breathing reserve, and a O2 pulse. So from this we kind of formulate a report, and we might find out the predominant cause of dyspnea amongst cardiac, respiratory, metabolic causes or ventilatory causes. So this is a CPET testing which we are kind of doing, and in this console the simultaneous values are being plot. The ECG is running and different so basically an integrated test. So integrated test which basically which we basically use to evaluate the cause of dyspnea if we are not getting a cause. Unexplained dyspnea is a systematic tired approach, so I'll not go much into details. So I'd like to call upon Dr. S.K. Pathak for the further session. If you have any query up till now.
Dr. Sapnil has connected a very core subject of the dyspnea, and he sailed through the very important issues which are misdiagnosed. And one or two questions can be asked for this core subject because it is not a very research subject. So I invite the audience, you can ask very core thing, and I congratulate you have sailed through especially the character of the dyspnea. That is wonderfully you have described, and very small things which are overlooked, and that is to be seen. So if one or two questions, if somebody has a query, I know everybody knows something, you know more, please ask.
Swapnil, it's really a wonderful presentation on a very common topic, as Dr. K.K. Gupta sir has already said. And I can just say that, in spite of all those history and physical examination which are very, very important, there are small tools which are available to all of us in our day-to-day clinical practice. One is pulse oximetry, we can all see the patients. Second is doing an ECG, which is also very cheap nowadays and can be done at any smaller center with a mobile phone as well. If the ECGs are normal, most of the time the cardiac abnormality of dyspneas are ruled out. But the one most important thing which is left in an ECG is a sinus tachycardia. If the patient is an unexplained sinus tachycardia, that has to be taken care of. Patient can have a pulmonary embolism, patient can have some pneumonitis, patient can have a heart failure of an acute onset where may not be some etiologies are really explained. So ECG and a small pulse oximeter, the two important bedside investigative tool. And all chest physicians, they should work hand in hand with the critical care physician and the cardiologist, and they should learn the basics of echocardiography. Because unless you are very well versed with the basics of echocardiography, we are very well enumerated all those basic parameters of echocardiography or critical care parameters. Because most of our critical care physicians, they see, and they do focus at the emergency department to rule out causes of acute dyspnea, which many times comes to us. They can see the IVC, they can see the cardiac functions. All those things are very important, and I definitely congratulate you for, developing all those cardiopulmonary exercise testing and EBUS and bronchoscopy and DLCO. These are definitely advanced modalities of investigation which we all should have in our city. And I congratulate that if you started with cardiopulmonary exercise testing, it's a very good tool for cardiac and pulmonary patients, which we all wish to have in our city, but because of cost constraints and lack of people awareness, we don't able to do it. So it's a wonderful presentation. All the best.
Thank you, sir.
Nowadays, a lot of things are, there's a lot of buzz about preserved ratio and impaired spirometry. How do you practically, approach this situation in a case of unexplained dyspnea and you get a spirometry and you get a prism-like kind of pattern on spirometry? How do you further approach or elucidate this?
So after a detailed history, once we get a spirometry of these patients with a preserved ratio and impaired spirometry, we might get a whole body pleth for these patients to look for whether there is a hidden obstructive small airway defect. So I think that is an ideal scenario, or maybe an impulse oscillometry that might pick up small airway defects that might be there. A radiology, a HRCT thorax will also be helpful for these patients. Basically, if the patient is not symptomatic, we might not do anything about it. We might follow up en route with the sequential spirometries in 6 months spirometries or annual spirometries for these patients.
And do
If the patient is symptomatic, then we might evaluate with respect to whether we can go for IOS or a whole body plethysmography, and might prescribe inhaled device for these patients.
That is one thing, hematology is not to be overlooked. You have to see the anemia, at the same time you have to look the polycythemia also. So they are the hidden causes of the dyspnea one has to look into. Thank you so much.